So you're assembly.
Idea, was it nursing or was it like, oh, COO? You said.
One, we're going to get started. We're going to have some folks joining us caught up in Chicago traffic and clinical responsibilities, but we want to get started because we have a packed day. You'll hear more from David. You can see in your booklets more about the agenda for the 2 days. David's going to share more about our conference goals and specifics of the sessions. But I just want to thank everybody for coming and being here and participating. We're excited to build on what we started in our first conference. Many of you are familiar with the concept of comprehensive care and strategies to defragment care for patients who are at increased risk of hospitalization, but we're very excited to have a team of experts from Loyola who are going to be helping us apply implementation science frameworks to that work. And grateful to all of you who have traveled farther than the Chicagoland area, to AHRQ, who helped us by funding a conference grant for this conference and our inaugural conference. And a special thank you to Deborah and Marshall Ways, who are here and have helped us in seeding some of the work in the Comprehensive Care Institute. So with that, I want to turn things over to David, who, as many of you know, started the comprehensive care program and wears many, many other hats that he will share. And yeah, thanks, David.
Thanks, Emily. Welcome, everyone. I just want to echo Emily's thanks, and thanks to Emily and Shwarya and Sydney and everyone who organized this, and the whole team from Loyola, and everyone who's really made this possible.
There's a clicker.
Do I need to do something here? I'll just use this. Okay, that's fine. So it's really a joy to have you all here. This is work that I personally am incredibly passionate about, and I know that many of you share this passion. And it's a really exciting conference for me, because this conference, even more than the one before, I'm excited to see what I'm going to learn. One of the amazing things is that the presentations, almost all of them are not people from U of C. It is a growing community, and you guys are going to share knowledge, and I'm going to learn from it. And as you'll see in some of the presentations we'll have even from the U of C, we actually don't know what we're doing. And you're going to help us. So selfishly, I'm really glad you're all here to help us solve this problem. We're in a period of incredible transition and tumult in the U.S. And I think that this program actually is responsive to some of the challenges that we have. And so I'm really grateful that we're all here to talk together. So let me just talk a little bit about goals. I think they're clear enough, so I won't elaborate in too much depth. But obviously, we're here to convene a bunch of critical stakeholders. And in the room are clinicians, program leaders, social service providers, people involved in policy, people with backgrounds in consulting, patients, people in hospitals, people in clinics, people interested in education. I'm sure I've forgotten important groups, but if we're going to succeed in defragmenting care and emphasizing relationships, we're going to have to do it together. There are also analysts here who've done critical work in helping us understand what CCP is and is not doing. We're going to be able to really engage together in discussions and share knowledge. As I've mentioned already, we have a lot to learn. I think the tools of implementation science, as you'll see, are critical to advancing what we need to do at this point, and I'm so grateful to the whole team from Loyola to bringing this. We'll also talk about some particular strategies that we think may be helpful bridging between the sort of hospitalist model with different doctors in and out of the hospital towards CCP through the rounder model. I think that's going to be important. And then a series of implementation science evaluation strategies that help us think together about how we implement and how we understand the effectiveness of intervention. And as we think about that, I hope that we will, through today and tomorrow's discussions, lay the groundwork for future collaboration. I think there's a lot of work that could be done even now in disseminating this work, but as much as I would love to see the model grow, I want the model to grow only if we really know it works. And so there's a lot of work that needs to be done to understand when it works and how. I'm going to show you some mixed results today of areas where the model's working and areas where it hasn't worked. And I think the more we're able to solve the implementation barrier, the more rapidly we're going to be able to improve the model, figure out where it works and for whom. So this is the agenda for today. You have it all in your book, so I'm not going to go through it in detail. But I want to just really emphasize that implementation science is sort of really front and center, particularly in the work we're going to do today, in laying the foundation in what we're going to talk about. And then, we're going to talk towards the end of the day today more about clinical models and social needs models. And then tomorrow, hopefully, sort of pull this all together into thinking about how we actually turn this into actions for the future, including actions to train the next generation of clinicians to work in these models. So this is in your agenda, but I wanted you to have the theme of where we're going. And so I want to spend a little bit of time. I think probably almost everyone, if not everyone in the room, has heard me talk about CCP. So I'm not going to repeat it again, except to emphasize a few key elements of the underlying theory that I think are easily forgotten, and then to talk about the very newest data and what it shows us. So at its core, what I think CCP is about the idea that relationships matter. They matter between patients and their providers. Do you know your doctor? Do you know your nurse? Do you know the team that they work with? And about the relationship among those providers. If you have different doctors in and out of the hospital, it's how do they work together? But also, how do you work with social services workers? And when do you value the relationship? Because you can defragment care and have those people, different roles done by a single person or a smaller team of people. I would say that the key lesson of CCP is that strategies exist to leverage the power of relationships. What's CCP about in my mind? It's about having the same provider care for you in and out of the hospital and what makes that possible. And the fundamental insight was that if we have a group of providers who only focus on patients at high risk of hospitalization, they can have enough patients in the hospital every morning that it makes sense for them to block out their time so that they can see those patients in the morning in the hospital and then in the afternoon see them in clinic. Now, you're going to hear examples of where that's not exactly the model, okay? But it comes towards that idea of bringing someone who really knows you into close touch with you when you are not in the setting where they usually see you, okay? And but I don't want us to lose sight of that. The Rounder model is a way of doing that without having the ambulatory part of it. It's a doctor who will see you in the hospital every time you come in the hospital, basically. So you get continuity across hospitalizations and continuity between your ambulatory doctor and the doctor who sees you in the hospital. So it's a step towards that. But I want to emphasize again, at least in my mind, what that fundamental idea is, which is that we're trying to defragment care, create continuity of relationship. Now, it didn't take, we knew from the beginning when we began with CCP that it wasn't going to solve everything. And one of the things we thought it would not address adequately is unmet social need. We thought it might help because of relationships and leveraging resources and things like that, but we knew there were limitations. So a number of years ago, we had the opportunity to get funding from the Robert Wood Johnson Foundation to create what we ended up calling the Comprehensive Care Community and Culture Program. And that began with the CCP model, but added to it systematic screening for unmet social needs to understand patients' unmet needs, a community health worker to work with the team to try to leverage those, and then a community-based arts and culture program to activate patients, to empower them to better address those needs. I see that as very much not just a complement to the CCP model, but sort of philosophically aligned in that you're trying to build relationships between the CCP doctors and a social service team. We're trying to strengthen the ability of the patient to engage in relationships and feel that they can work and that they have trust and knowledge and communication building. And as I will show you in a moment when we look at the data, I think you're going to see that this addition matters. And so when we talk about implementation, we're going to be talking about implementation to meet the patient populations that each of us are caring for in the settings where we are. And I think different populations have different needs, and therefore we're going to need different programs. And if we don't recognize that up front, we're going to be working, against a tougher, wind. Okay. Oops. This is not advancing. I do not know what's wrong. Does this work? You just advance one slide and I can talk while you're working. There you go. Okay, so what have we learned? First thing we've learned is that patients love this care. Patient satisfaction rating your doctor is at the 95th percentile. It stays there for 2 years after people are randomized into this. We know that mental health status improves. This may not sound like a lot, but 1 in 25 patients move from stating that their mental health is good, fair, or poor to excellent or very good in an RCT. That's like as good as antidepressants, frankly. Okay. Resource utilization is obviously critical for this, one of our clinicians. So what do we find? Hospitalization decreases by about 15%. This is statistically significant. And it's about about 0.3 hospitalizations per patient per year. In other words, 3 patients, and in one of them, we're going to prevent 1 hospitalization in a year. This is a huge effect compared to what's out in the literature. The complexity really is with cost. We don't see at this point overall a statistically significant reduction in cost. But what we do is we see it in certain groups. And I want to talk about that heterogeneity because that heterogeneity is key to implementation. First, when we look at hospitalization, what we see is a 30% reduction in hospitalization in non-duals. In other words, patients who don't have Medicaid, just Medicare. And that is a huge effect. But in dual eligibles, in other words, patients with Medicaid, the lower income patients, we do not see a statistically significant reduction. It's about an 8% reduction, but it's not significant. Now, that's one stratification, and I've already talked about some of the reasons why I think we see that difference, and we're already working on models like the Comprehensive Care Community and Culture Program to address that. This is from the original study that didn't have that. The second thing that turns out to be a huge stratifying variable is distance. We didn't include patients in the study who lived very, very far away, but we allowed them to sort of participate if they felt they could come here. Unfortunately, what we discovered is that patients who live more than 10 miles away may have very good intentions, but aren't able to access the program in the way we want. So what do we see if you live less than 10 miles from the U of C? We decrease hospitalizations by 20%. If you live more than 10 miles away and you enroll in the program, it looks like we actually increase hospitalizations by about the same amount. Now, that's a tiny population of people, and for a variety of reasons I'm going to show you in a moment, they may be effects that are biased. But there are lots of reasons to believe that there's something real going on here, and I'd like to delineate those for you because we've now understood it pretty well. The first thing is that patients who live more than 10 miles away are very unlikely to be able to get here in an acute illness initially. So what happens is they get admitted to the way ambulances work in this area. In many areas is you get sick, and if you get taken by public ambulance, you get taken to the nearest hospital, even if you ask for something different. Okay? So what happens is they get admitted to a hospital far away. They're there in that hospital for a few days. Maybe they're getting definitive treatment, but often they're not. And then they end up being transferred to us, which basically turns one hospitalization into two. Once we control for those costs of sort of the second hospitalization, all the cost differences we see in the group that's further away disappear. So that seems to be heavily driving this. The other thing is decreased engagement in primary care. It's very difficult to parse this out exactly, but we see evidence that the patients, particularly the dual eligibles who live far away, have a great deal of difficulty getting to us for primary care. It's one thing to sort of drive your own car or have your, spouse drive you. It's another thing to try to get, publicly available medical transport to get you all the way here for a primary care visit. And so even though those patients actually come and see us a fair bit, they probably need to be seeing us much more than they are in fact able to. And so these two stratifications are really important, and I'll come back to them in a second and show you. There's a last issue that I want to highlight, and these last three bullets, I'm sorry they're so dense, but this is what I'm summarizing is basically an hour and a half talk, okay? And what it shows is that all these savings that I'm describing to you are underestimated. And the reason they're underestimated is that we are measuring resource utilization in Medicare, traditional Medicare. And as many people in the room know, there's been this very large transition from traditional Medicare to Medicare managed care. And what people tend to do is go into Medicare managed care because they can save money on premiums and co-payments. And they do that if they feel pretty confident in their health. If they do not feel confident in their health, if they're sick, they stay in traditional Medicare. And it's those whose data we measure. And it turns out that sick patients are more than twice as likely to stay in the CCP program in traditional Medicare than healthier patients. So we are selectively retaining those people, which means every estimate that I'm about to show you about costs is an underestimate. And I'll be able to show you sort of some sense of the magnitude of that. So this is an incredibly complicated table. James and Wei, who are sitting there, are the spectacular analysts who have helped us look at this. It's been hands down the most complicated analysis I think any of us have ever done. And I want to highlight sort of a couple of things. First, over here, if you look at the full sample in the entire randomized trial, it's basically not significant. But if you break it down between non-duals and duals, there's a very strong trend towards savings, not quite statistically significant, of about $4,000 per patient per year in the non-dual. So this is the group without unmet social need as much. This is the group with unmet social need. It goes sort of the opposite direction. Now, it turns out, that a lot of this is very temporary. So when we analyze this going out through the year, we initially see utilization rises. We think one of the reasons why is our great clinicians see these patients, discover they have unmet need, and by the time you reach the end of year one, this upward thing is actually going away. So that's part of the complicated analysis I'm not showing you today. This is the sort of overall effect. Then when we stratify according to distance, this is less than 10 miles, that's more than 10 miles. What you see is that now this number is starting to go negative overall. This number is starting to go towards zero. No, not it's significant. And then this, which is the non-duals nearby. So this is the group without this extreme unmet social need, but who we actually can treat. We're saving about $5,500 per patient per year. This is a number, a huge, huge number in an RCT. Okay, now that's the good news. The bad news, sort of, is over here. These are the patients who are living more than 10 miles away. And in these patients overall, you see a non-statistically significant trend overall towards, if anything, higher costs. You see in the non-duals, basically, nothing statistically significant. And then you see these group. These are the dual eligibles who live far away. And we have spent most of the past year digging into this beyond almost the point of reason, trying to understand what is going on with these patients. And so I'm going to give you the gist of what I think is really happening here. There are a couple of things. First of all, I don't think the model is ideally situated for these patients. They live too far away to optimally benefit from it. Okay? So they're not getting as much primary care, and they're getting hospitalized twice. The second problem is that, they're, in addition to sort of not getting the care, is that there's extremely powerful risk selection going on. So remember how I said earlier that we are holding on to the sick patients? If you live nearby, you are going to get care from us whether you like it or not. Because if you choose to come here, you're going to come here. And if you choose not to come here, the ambulance is going to bring you. Okay? So there's very little selection there. These green numbers here are a quantitative estimate of the relative tendency of sicker patients to stay with us. And they're green because, although it's bad news for our costs, it's good news for whether the model really works. And what you see here is that there are favorable effects here. And one way you could, if you want to try to roughly convert this to dollars, multiply this times $100,000. So basically, that sicker person tends to spend about that much. So if you add savings like that to these numbers all go very, very, very negative. But what I want to point over here is these numbers. See how this number is like a 0.06. This is a 0.05. This is a minus 0.17. In other words, absolutely huge selection. And what I can tell you is if you signed up for the CCP program living far away, and then you stay in this program despite all the barriers that exist for you if you're far away, it's because you really want to see Grace and Joyce and the other CCPs, because you need it. And so this turns out to be a huge part of this. Now, how good news is that? It's kind of good news and not so good news. It's good news in the sense that what this says is we are helping people and helping society. It's not such good news in the sense that if you're a health system CEO and you're asking, are we really making money for your accountable care organization? We may not be, okay? Because we are holding on to some of these sicker patients who, if you're at risk, you're going to have to pay for. And I'm personally of the belief that the way the U.S. healthcare system has gravitated population-based risk in many contexts has made the business of healthcare much more about avoiding caring for people who are sick than actually doing a better job. And that's another headwind that we have to fight against. Now, if we focus on this group that's nearby, that's a lot less of a problem. If we focus on a group here, like, don't take care of poor people who can't help themselves. Well, that's a business model. I'm not advocating that business model. What I'm advocating for is we need to build intelligent programs that help extend to this population as well. But should we be focusing on these patients? Probably not. So this begins to raise an implementation science question. Where do we implement this program for success? And if we implement it in a setting where we have social need, are we going to add the interventions to address social need, which I think. Okay, additional research update. We are aiming to publish this study later this year. We hope to submit in the next month or two. There's a draft. We are meanwhile working very hard on our second big study, the PCORI C4P study, which includes CCP plus unmet social needs screening, the Community Health Workman, the Artful Living program. We have been working incredibly hard on this. We've enrolled about 1,800 of 2,400 participants with complete enrollment expected by June of 2026. So we are within range, and that target date for enrollment, barring another COVID should absolutely go ahead. Like, we are on track. What are the interim results show? Again, improved patient experience, increased PCP visits with CCP and C4P. I want to highlight that because we didn't always see that in the original study. So we're seeing much more consistent engagement with primary care, and we think it's because of all the social supports that help patients engage. We see that hospitalization is down 43%, particularly for C4P versus CCP in the group that is not activated to engage initially. So we think it's really working for these patients who we didn't engage before. Follow-up should be complete by June of 2027. We should have interim and final results sort of later that year and into the next year. I mentioned the Medicare Virtual Research Data Center. One of our big barriers in finishing these studies has been linkage to Medicare claims. There's now an opportunity to get Medicare data in real time from CMS. And, we've made the investments to do that. And those are investments that we can leverage to work with other institutions as well and turn the delay from several years to several months. There have been a lot of key implementation lessons from this. We've learned a ton over the years. We've now integrated CCP and C4P into our local institutional budgets and operations. We've got CCP both here at U of C on the main campus and at Ingalls. And those partnerships continue to grow and develop, and you're going to hear more about some of that both today and tomorrow. But I think that's positioned us to be able to help others think about these transitions. We've had to adapt our social services program across the pandemic. We've also had changes in our social work and community health worker staffing, and we've learned to be robust about those. One of the hard things about programs like this is they're intrinsically small, and you're dependent on a very small number of people. And no matter how devoted any one individual is, things change in their lives, and you have to be able to respond to that, and that's been a lot. But I would say, if I look overall at the single biggest set of issues in sort of generating data, it's been our ability to recruit. There are only so many patients we can recruit at one site, and what we desperately need to be doing is having this implemented at many sites so that we can recruit together and recruit faster. And that's one of the reasons it's so important in being all of us here together today. So we're going to be focusing on implementation. We're going to be talking about defining the program elements. Are you in a setting where CCP alone is probably enough, or do you need C4P? What's your local market like? Is everyone going to come to you regardless of how far away they are, or do you need to focus locally like we do? Are you in a competitive market or a not competitive market? How do we get more patients into the program? What should the inclusion criteria be? Should there be better risk prediction models to try to affect this? Should there be more effective recruitment techniques? We've done a lot in training our research coordinators in motivational interviewing. We've had amazing progress recruiting in the emergency room. That has been invaluable for us. We've been working on community-based recruitment. I will be honest, it's been challenging, but important. And then, as we add more sites, how do we implement? How do we lower the cost and increase the breadth of implementation, including in community hospitals, teaching hospitals? How do we increase the speed with which people can implement? How do we increase the willingness and eagerness of institutions to implement it? And how do we lower the cost of data collection so that we can take finite research grant dollars and make them go further? Now, let me say these are all problems in translational science. And people may be familiar with these sort of nomenclatures of T0 and T1 and T2, T3, and T4, various stages that start with basic science research and bring it all the way out into the community. And one of the things that, if you're familiar with this framework, you also know very well is that translation can take a really long time. There's a classic, statement that 17, 19 years it takes to translate an idea from basic science into practice, and that along the way we lose many interventions. I would say that this is actually probably more optimistic than I would describe it. And I want to give an example. I will say that I created this example because we're doing collaborative work with in dentistry out of the CCP program, and this was before I knew who our Secretary of Health and Human Services would be. So let me say, So we're doing this dental work. I know very little about dental health, but I've heard of fluoride. And I'm like, how did fluoride get started? I had no idea. So here's the story. In 1901, there's a town in Colorado where they discover a bunch of kids have discolored teeth. And some dentist there notices not only are teeth discolored, they don't have cavities. And then they discovered a new town in Idaho where the same thing starts happening after they drill a new well. So they look in the water, and what do they describe? Fluoride in the water. They're like, fluoride is causing discoloration of teeth. And then someone's like, well, maybe if it were a little less fluoride, you wouldn't get cavities, but you wouldn't have discolored teeth. So they show by the late 1930s that low fluoride levels don't cause discoloration but protect. In 1945, Grand Rapids, Michigan is the first city to add fluoride to the water supply. And in the 1940s to 50s, the first RCT fluoridation is completed. Now, my wife's the Associate Dean for Medical Education at U of C. And she tells me, that was all discovered at the U of C. And I'm like, really? And she shows me the website. It says, research at the University of Chicago leads to fluoridation of water nationwide. I'm like, I read the history. I'll just think it's a little overstated. Okay. By 1980, half of Americans have fluoride in water. By 2012, 3/4 of Americans have fluoride in their water. By 2020, we're not quite making so much progress. 77% of Americans have fluoride in water. And now here we are beginning to take fluoride out of the water. Okay. So I want to point out 20 years, 17 years, 1901, do the math. We're 125 years out of the initial discovery, and we still don't know what we're doing. Okay. So translation is really hard. And so I want to steel us for that. There's many steps here. And I think we have, I don't want to say proof of concept, but evidence of effectiveness. And our real challenge is to figure out how do we turn it into impact in hopefully less than 125 years. Okay. One of the problems in translation are these valleys of death. We're gonna hear a lot about that from Elaine and our colleagues from Loyola. And along the way, from fundamental research to practice, investment may rise and fall, and often things will die. This is a problem that is appreciated by NIH, and one of the most important programs for doing this is the Clinical and Translational Science Awards, and we have an Institute for Translational Medicine. It's part of our CTSA program. It's a program at U of C and Rush. It's part of a big national consortium, and it's aimed to help promote translational research and translational science that advances health equity. The University of Chicago's program, as I mentioned, is a partnership between U of C and Rush and another set of Chicago area institutions, Advocate Aurora, IIT, North Shore, and Loyola. It was started by Julian Solway, who sits here as the very happy director emeritus. He is an amazing convener of people, and this is an amazing set of resources around the Chicago area for collaboration. And just the whole Loyola team, I'm so grateful for, because they broaden our collective expertise in implementation science just critically. The other amazing thing is that the ITM is just one of these hubs nationally. There's more than 60. There are 2 other in Chicago with Northwestern and UIC, and we work together. There are a whole series of grant opportunities working with the CTSA consortium. Wisconsin and Vanderbilt, other places in the room have these connections as well. There's a huge opportunity for us to do this. And they are certainly not, looking to see translations happen in 120 years. Okay. Now, as we talk about implementation, Lane and Fran and everyone from Loyola helped us distribute some pre-conference implementation surveys about the value of CCP. And when we analyzed this data, at least we had about 6 different places respond About half had fully implemented, 2 partially, 1 considering, 1 not. I guess it's actually 7. Sorry, I did the math wrong. Yeah, didn't update that. And there were perspectives on how CCP will produce value for patients, providers, payers, program managers, and policymakers and hospital leaders. And Elaine's going to talk about this in more detail. But I want to say, as I looked through the answers, I was struck by a couple of things. There's a lot of agreement about how important it is to engage patients and providers together in prevention and in crisis with continuing relationships. As I looked at the provider perspective, it's very interesting because there was a tension. On the one hand, being there, being present, engaging. On the other hand, having support, having a team around you. And those two are both, can be complements and can be substitutes in intention with each other. And so these are some of the things we need to think through when we think about care models. I was also struck in talking about payers, how clinical the answers were. It's about preventing errors, improving care. Well, remember what I just showed you. Like, what drove the economics of this? It's, are you actually retaining sick people or doing risk selection? And we're not thinking like that. We're thinking like clinicians. Program managers, all I can say is sort of God bless them. They are just trying to hold together these diverse interests and get it all to work in a complex world. And then when we look at policymakers and hospital leaders, and frankly, we're mostly talking about hospital leaders, it's fascinating because they talk about improving performance on value-based contract, like reducing total cost of care. They talk about cutting length of stay, a totally different business model. They talk about preventing readmissions, sort of related to length of stay, but quite different than population health. And some talk about attracting business. And this is a reminder that the U.S. healthcare system is this incredibly complicated amalgam of differing systems and differing incentives. We have folks here from Kaiser who have a very different model than many of us function in. And I think that we can't ignore that. And, as much as I wish we could just think about just doing the right thing, just making the world a better place, making people healthier, we've got to figure out how we fit in these business models, at least to the point where we convince the people building the models that what we have to offer is so important, the business model needs to respond to us. Okay? So those are some of the challenges that I see coming. So let me stop there. I hope I haven't gone over time too much. I'm happy to take a moment for questions if we have it, or whatever seems good to people. No. Can I ask a favor? Whenever someone raises their hand, would they please introduce themselves? Because one thing we haven't done is gone all the way around the room, and I really do want to get people a chance to meet each other. So
Ed Vasilevskis, I'm the division chief at University of Wisconsin in Madison, and that was really fascinating. Curious about the distance. I do think that's really important, especially when you think about cities, where you live. Madison, of course, is a much smaller place, and so the 10 miles, it seems to be somewhat arbitrary. I'm wondering.
Most of us have 10 fingers.
Yeah.
Based on that.
Yeah. So I was wondering what the magic of that number. So it sounds like.
So the number is not at all magic.
Yeah.
And we've played around with 5, with 10, with 12. What I've shown you is actually not optimized.
Yeah.
Like if I were really going to and James literally was doing this last week, probably it'd be more like 12. Okay. And it's related, but that's here.
Yeah.
And there's a lot of different ways to think about it. There's driving time. I don't know if you know this literature, but there's an economic literature on how you define markets. And one of the ways to define market is distance-based. Another way is by basically, what are the edges at which if you change a price, people will move from one thing to another thing, like this hospital to that hospital. That's probably a better way to think about doing it. And of course, it's very different for different people. So it's empiric. That's the honest answer to it. I will say that it's quite clear that when you get far away, people are not engaging and this is happening. And whether it's 10 or 12 miles or 8 miles or as the crow flies or driving time, none of it fundamentally changes the directionality of the results. And just one other thing to remember, we're doing huge RCTs. Okay, we're doing 1,000 patient per arm RCTs. That's the size of the Rand Health Insurance experiment. How many people live between 9 and 12 miles? Out of that, you're talking about 50 people, 100 people. So like, what is the statistical power to answer that question? I don't come close to having it. But what I do know is that it's an issue. And when we think about how we define catchment areas for these programs, this is something we probably need to be thinking about, right? And it's going to depend a lot. Like, I don't know Madison that well, but I do understand that there are some private health systems there, and you probably face some degree of competition with them. And understanding, how that's going to play into this seems very important. The other thing I just want to point out is data flows are important. When we were doing this, the ability to capture costs in Medicare Advantage is extremely limited. It's a little better now. Maybe there are ways around some of this. So I think these are design issues we're going to have to think about. Yeah.
Hi, everybody. Niraj Mendrada. I'm from Kaiser Permanente in Mid-Atlantic States. Started the complex care program there. David, I'm really intrigued about the distance part of it. Even though we are an integrated model and our patients are in the corridor of DMV, access is a really important thing for us. Something that I think we've gotten right. I'm intrigued about virtual care. So when you think about the distance, some of the things that have mitigated, and we learned a lot during the pandemic of how to connect to patients virtually. Although there's some studies coming out on that as well, especially with a complex care patient, comprehensive care patient who's, social determinants plus the medical management of those patients. Is there any thought about still being able to connect with patients virtually and provide care?
Yeah. So I think yes. And I think you also need to recognize the challenges in what you can do virtually and for what set of patients. Socioeconomic status is traditionally measured and ability to do digital health aren't necessarily correlated, but there are certainly times when they are. And I want to point out that the place we see the biggest problem with distance is in the dual eligibles. Okay? And so I think the answer is yes, it can help, at least for the engagement in primary care. But I think you want to think really carefully about what sort of ability to do that patients are going to be able to do. Like, I did a lot of virtual visits during the pandemic with a very socioeconomically diverse set of patients. And some of them were just all over it, and a lot of them really struggled. The other thing I just want to point out is, given our results, going to a hospital that is not your hospital is a big problem. And your model is a little different than ours because you don't own your own hospitals, right? So you have sort of more hospitals, but doctors who go to a bunch of different hospitals. So I think that's a very promising model. And one of the things you'll hear tomorrow in the context of education, and is there anyone here from Ingalls today? Oh, that's good. Oh, yes. Used to be at Ingalls. So Ingalls is a community hospital that's part of the U of C's network. We have a CCP program there. And a lot of our patients who are in this program who live as more than 12 miles actually live really close to Ingalls. And I would argue that probably there would be a world where they would be better off in a program right near them where they could actually get that. And so, I think there's a lot of different ways to do this. And for our whole implementation science crew, this is a really big, complicated problem. Because we all live in different networks, different geographies. There are so many different versions of this. How much heterogeneity can a study handle and still be a study of a thing? And I think that's something I'm struggling with and would love guidance on. Okay.